Helical is a leading national health magazine. On the behalf of Double Helical, I welcome to all. This is our first seminar, and I hope this will be enjoyable and very informative, so that we can go ahead to highlight our edition among the doctor fraternity. Thank you. And now I'm hand over to Dr. Gyani to moderate for the today webinar.
Okay, good afternoon and good evening.
Good evening.
When I keep wondering, Dr. Vinay will agree with me, that we sleep COVID, drink COVID and eat COVID. That is what is happening. All COVID around us, And I don't know what is this kind of pandemic. I am calling, this is not really a deadly, but it's so contagious that, it has generated an element of fear among
Gyani sir, you have muted yourself.
So, why I'm saying, why we have, fear among all of us. Because till today, Dr. Sanjeev will confirm to us later on, we have not been able to understand the behavior of this virus. And that is a whole, the problem around us. Now, issue here is that we have to
start video
SOPs, guidelines, we have to provide appropriate equipment, what we call PPEs, to our doctors, nurses, and paramedical staff. Because, and over and above, we will have to generate, a kind of teamwork around, the doctors and nurses put together. They are confident in the treatment of the patient. Now, I'm otherwise afraid that if you are not able to do that, that means our healthcare professionals will be worried more about themselves rather than worrying about the patient. Many guidelines have been developed. One such guideline, which is very comprehensive guideline, was developed by AHPI along with the PHA5, and where Dr. Sanjeev Singh, one of the authors, and who will be sharing with us what are the safety management guidelines for hospitals, for the nursing home, and more importantly, clinics. Because while major hospitals are able to take care of the safety management to a great extent, worry more about the smaller nursing homes, so about the single doctor clinics. And that is where I have requested that Dr. will be sharing what we call safety management of the hospital, nursing homes and the clinics. Now, one aspect which I want to mention here is, Sanjeev will be the key speaker, and I would be requesting him to take about 20 minutes time. But this is the one webinar where I am seeing that 4 senior experts have been requested to come in. These include Dr. Sunila, Garg, Dr. Arun Aggarwal, Dr. Vinay Aggarwal, and Dr. Vijay Agarwal. I think those of you who know them, they are institute by themselves. So in fact, this is one webinar where that people have been brought in to share their thoughts and guide the who are participating on this webinar about how do we become safe ourselves first, and then we are able to provide that safety cover. All this I think is going to be covered today. So I am very happy that Double Helical has taken this initiative, and I will, without wasting time, I will request Dr. Sanjeev Singh to start his presentation. Dr. Sanjeev Singh, of course, has been the person very well known in our community. He is the one doctor who has done the doctorate in the infection control, and who was not till recently, even now, of course, the medical superintendent at the Amrita Institute of Medical Sciences. But he has been now co-located at Faridabad, as Amrita is setting up the medical college there in the Faridabad. So I will now call upon Dr. Sanjeev Singh to start his presentation. I will also request the technical team that please make sure that when the speaker is talking, all others should be muted. Well, I am seeing there was some disturbances coming from some other sources. That should not happen. Dr. Sanjeev Singh.
Yeah, thank you very much, sir. I think host took your advice and they have even silenced my video as well. So they possibly took it very seriously. So yeah. So in any way, I'll till that thing is sorted out. I have mentioned it to Sugar. Till that is sorted out, we'll get started. So right, perfect. So thank you, Gyani sir, for the kind introduction and the opportunity to present the work which has been done under your tutelage. You're able to see the screen, sir? Okay. So I'll be talking about safety management at small nursing homes and clinics during this pandemic time. And on the right-hand side is the book which was released, which was a joint work between Vijay and PHFI. And thanks to Dr. Gyani and Dr. Alex's leadership, along with PHFI, that this work was done. So this is how I'll be covering. I'll possibly do it faster because some of the time was wasted. So situation and how do we need to respond to the workflow. Before I start, I would like to dedicate the presentation to all these healthcare workers who are no longer with us and who are warriors, and then they succumb to COVID. So there are close to 1,503 healthcare personnel and 33 in India who are no longer with us. So we lost them. Now, the point is they were all frontline warriors during the pandemic time from January onwards. And why did we lose them? So possibly because we didn't know much about the pandemic. They were caught unawares. We possibly underestimated pandemics. There must have been some breach in infection control practices. There were lack of testing facilities when we started, and still right now in some of the countries there could have been a shortage of PPE, and we treated that all age is all are equal and there should not be any problem. And that wasn't the case. And this is where we need to bring in the safety aspect, that we need to have that standard precautions and universal precautions all the time. You must have seen this graph so many times, and I'm not touching on the general statistics because everybody knows the statistics. What I'm trying to touch is fantastic example with respect to Taiwan and South Korea. An Indian graph also was at that point of time. And what helped was lockdown. That's why it is bold. And what's now going to help is physical distancing and masking. So if you follow that, it would be appropriate. Now, there are so many guidelines. Your WhatsApp, your Telegram, your Instagrams are all flooded with guidelines. So where do we reach out to them? There are Ministry of Health and Family Welfare, NCDC. So these are the three topmost bodies which are coordinating it together from India. And then there is Government of India, mygov.in, where COVID updates are available. I'll just take a second to explain what Kerala had done and why this model is working and why Kerala was able to flatten the curve. It was because of a fantastic public-private partnership, which was formal and some of it was informal. So there was this participation, there was a state command center, and then they worked fantastically well. So it all started with the district magistrate who was there, posted in Pathanamthitta district, and he found out that if there is a case which is there, so he did an electronic surveillance, and there was a route map which was established. So this Italian tourist who came in, flew from Moscow, Delhi, Trivandrum, and then he picked up a taxi driver. His time has been identified. Then he went to the beach resort. His time has been identified. Then he went to the center. He went to the restaurant at what particular time. He went to have a lunch at this restaurant at what particular. So this is a detailed map. So in Kerala, what happens if there is anybody who is tested positive, his route map comes into the social media and the website, and everybody looks forward to that route map, and then they self-declare. And they also have empowered Kutumbashri and Asha workers to also whistleblow if people are not. So they did more of quarantine rather than test. The precaution as a community which we should take, and if there is a success story, I think which we should follow. So I think this is all very well done. Everybody knows about it, so I will skip. So what are the myths now which is traveling, that as we getting into a hotter and humid climate, COVID will go away, which is untrue. Cold weather and snow cannot kill COVID, untrue. Hot water bath taken COVID will kill COVID, untrue. Mosquito bites transmission, untrue. Vaccine and against pneumonia will protect, untrue. Regularly rinsing your nose with saline, untrue. Eating garlic, antibiotics, all untrue. So unfortunately, there is so much of news, and there are so much of fake news also. So clinical management still remains the same. I just wanted to cover because of the small and the care from a litigation, CBC, chest X-ray, serology, and symptomatic care. If it gets severe, which is a respiratory rate of 30 and SpO2 less than, and PF ratio of less than 300, then there would be a secondary infections, hydrochloroquine, azithromycin, cytokine, strom, plasma therapy, steroids, which we need to give. In the lab, it is very simple. NL ratio greater than 3 would be very confirmatory. So after the lockdown, what we need to do? So we need to open all facility, OP, ER, IP isolation. So every facility needs to have their own screening triage and PP, physical distancing, hand hygiene, and disinfection. What we need to be very, very careful is some of these special situations. When we look at opening up the facility, special precautions needs to be taken, and we'll see. And if you can also put in telemedicine, home health, and elder care, that would be fantastic and a great service to the community. So now triaging, how do we need to triage? So staff will come, car park will happen, security lifts, and then at the entry point, they need to, the staff needs to follow a separate path, the visitors needs to follow a separate path, and there would be a separate area. And once they finish, they go back and follow some of the precautions. So if
no voice, please. We can't hear you, sir. There is no voice at all.
Actually, I have already मतलब hello, मैंने सबको unmute कर दिया है. Hello. सर आप फोन रखो, मुझे करने दो एक मिनट.
मोबाइल आपका म्यूट हो गया सिस्टम सर. संजीव जी.
Yeah, we can't hear you, sir.
Is this okay?
We can hear him. Sir, please.
Okay.
Yeah, Sanjeev, now we can hear you, sir.
Now we can hear.
So this is the waiting area distance which we need to maintain, and if there are COVID symptoms, they go to fever clinic, and that is a complete separate workflow. And if they are non-COVID, they go into separate area, and all universal precautions needs to be maintained. So if you identify a high fever and at least one of the symptoms, have a patient place a mask, and then according to ICMR, look at the various guidelines. If they're coming from hot red zone and containment zone, and if they have ILI and SARIs like symptoms, then they need to be treated separately. And if they don't have symptoms, then that is perfect. So what is best right now is that the telemedicine practice guidelines have been from the Board of Governors in MCI has been released, and that has been adopted. So even a telemedicine consultation is legal now, and that has been adopted by Ministry of Health and Family Welfare. So they have included it under Professional Conduct and Etiquettes Act. So you can consult through all these channels, either through video, it could be a WhatsApp video, or it could be any video, it could be an audio or by text. So that is all permissible and it is covered. So that's a fantastic step. You cannot use telemedicine for surgery or any invasive procedure. You also have to undergo a mandatory online course, but that could be within 3 years. So right now, maybe this is required and you don't have a choice, so you can carry on, but mandatory online course is required. Avoid all emergency consultations. So listen to all the signs and symptoms, then refer them if they require an emergency consultation. What was fantastic is Section 4, because in India, though we say it is a patient-centric hospital or patient-centric care, but it is equally a carer-centric care, because the bystanders and attendant also participate. So what they have allowed is resident medical practitioner to patient consultation and also caregivers consultation, which is also allowed, but the resident medical doctor needs to maintain the documentation. So the core element for telehealth is that you need to identify yourself and the ID. Is similarly, the patient ID, age, credentials have to identify. So if you are having a teleconsult, this is something which is mandated. You can do a communication through all these channels. The consent is implied. So you need not take another consent. And if they are having a video consultation, that would be perfect. Type of consultations, it could be through telemedicine or in-person consult, that's okay. Patient evaluation, first consult, and 3 to 4 weeks or still 6 months, they have said it would be a follow-up consultation. So that's the core of telemedicine act. Patient management, you can do health education, you can do counseling, and what is perfect is you can also prescribe. So up till now, it was prohibited, not encouraged, and medicine of list O, A, B, and prohibited drugs have also been highlighted. So you cannot the anti-cancer drugs and narcotics cannot be prescribed, but all other drugs can be. So you can give the prescription directly to the patient or to the carer or to the pharmacy shop. But you need to maintain a log. They have not specified the fee, so you can charge. You're free to do it, a free consultation, or you can charge. So there are some general guidelines when you open up the temperature check, reusable, hand wash, sanitization, and appropriate signages are what would be important. What is also key is intensive training for good hygiene practices for all people all staff who comes in. So right now, many of them, they have allowed 50% of the staff to come in and 50% of the staff still work from home, and that is an alternate odd and even kind of a variety. So when you start your OPD, the checks are done. If you are in a fever clinic, you are full on, and adopt any innovative measures which you need to adopt in your OPD. So that would be fantastic. But in the waiting area where the patients are sitting in, have adequate signages, maintain that distance, keep a hand sanitizer, and keep posting the signs, because hygiene and cough etiquette would be important. So this is the visitors triaging workflow, which is been already given by ICMR. A lot of people say that we have a small clinic and we also have an air conditioning. So what do we do? So ISRE and Government of India have come up with a guideline. What I would like to specify is air conditioning is fine. Air conditioning and air handling are two different things. So we should not confuse that. We need to maintain the temperature. So best is to have a window and a door and a ceiling fan, because I don't know. Oh yeah, I have the slide. Because open window, this is a CDC slide, open window 100% with an open door, you're achieving 37 air changes. So what is required to achieve is 6 to 12 air changes. So we are going back to our basics, what we used to have as an isolation wards in our medical colleges. 50% open window, 28 air changes. So this is fantastic. If you still have an air conditioning, you need to take care of air handling rather than air conditioning is allowed. A recommended temperature is 24. Now, a lot of people have asked, how do we treat? Is there anything different if for non-communicable diseases? So WHO has come out with a guidance note. There is nothing different at all with respect to NCD. We need to be very careful with people who are 60 plus. So again, there have been a lot of queries because there is an ACE2 receptors within the COVID. So there have been queries whether ACE or ARB drugs needs to be redosed or re-prescribed, and there has been a guidance note. The treatment would go as it is, and there is nothing else which we need to change. So tips for people living with NCD: you need to continue your keep your supplies, continue your medications, and follow safeguard, but do keep your mental health fine. So if you come back to swabs and sampling, there have been a lot of queries. A lot of hospitals are sending one sample. There has to be a nasopharyngeal sample. There has to be an oropharyngeal sample. Every time you have to send two samples. Samples have to be sent in VTM medium, and you need to wear PPE when it is sent. So when you are sending this sample, it needs to be in an absorbent material, and then there has to be a cool pack and has to be sent properly. Once that is done, please check whether everything is appropriate before it gets into a testing lab. If you have a testing lab within your facility, that would be fantastic. Now, there are a lot of questions about RT-PCR, antibody, antigen test. If you see, if you have a symptom, this is a symptom-free time. So unfortunately, this is where the asymptomatic people belong to, and there are lots of infection. So this is, unfortunately, is not covered. In week 1, you can do an RT-PCR, and that is likely to be positive. Now, with the problem with an antibody testing or detection is that it is all coming from 9th day onwards, IgM and IgG. And that is where it may not be very, very helpful. So you can do a nasopharyngeal bronchoalveolar lavage. In a lot of patients, especially pediatric patients, stool PCR is also done. So they also need to, our healthcare person needs to follow all these precautions. Emergency department, please take special precautions because they all need to wear all PPE, don't take any risk. And if emergent procedure is there, go ahead and test the patient. Now, every procedure needs to be differentiated into non-aerosol generating and aerosol generating procedures, and these are areas where we need to be extremely careful, and this is coming from CDC. When you do an airway manipulations, NGOG, tube, PE, extubation, surgery, only these surgeries that aerosol is generated, bronchoscopy, endoscopy, CPR, and dentist. So this is where we need to be extra cautious. Now, there has been a lot of queries that the patient is positive, so should we immediately send a patient to an isolation room? The answer is no. They could be there in the ward and they could all be cohorted. Now, this is a cohort ward, and unfortunately, I could not see any drawing, so I made the drawing myself. The doctors and the healthcare workers come in, and they all don here, and they come into the ward. The 1 meter distance between bed to bed is maintained. There is a window for adequate ventilation. There is a very high degree of exhaust, which is there, a dedicated washroom. When the healthcare workers come out, there is a doffing, but doffing area has to have an exhaust and all biomedical waste management and hand wash technique. Post that, the problem is with shower in most of the hospital, and that's what is recommended. So you need to have a shower post doffing, and if you have removed your clothes here, PGI Chandigarh has given this idea, which is fantastic, innovative. You can have a wheel-in lockers, and they come in at the shower area. Room cleaning, you can do it just a 1 hour of gap, which needs to maintain, and it would be a bleach cleaning, and that is good enough. Discharge policy has been changed. You need not investigate a patient. A good 3 day of symptom free is good enough for mild to moderate people to get discharged. I'll skip this because it was a small nursing home for. If you have a COVID positive, identify primary contacts who have been direct or secondary contacts for the healthcare worker. PPE mask is perfect, and unsterile gloves and shoe cover is what WHO is still recommending. For aerosol generating procedure, N95 and goggle shield is what is recommended. What is most important is when you remove every step, when you're removing PPE, hand hygiene at every step is important. You can reuse N95 mask by hanging by hydrogen peroxide vapors. How do I know whether everything what I wear is certified? So DRDO and CITRA certification happens, and then there are some international classification. So special situation, some of the hospitals have initiated consent, and that is a fantastic way to proceed, so that it is very clear between you and the patient that all these tests would be required and all this management would be required. In case of surgery, it would be best to, and this comes from the World Journal of Emergency Surgeries, if there is a person who's transferring a patient, so from ward till the OR, and from OR again back to recovery, there should be a single group of people who transfer. So you cannot now do a ward to holding bay to pre-anesthesia, pre-anesthesia to OR, and OR again to recovery, and recovery to ward. If that could be avoided, that is the best. So least people gets infected. Route has to be fixed, shortest distance. Materials have to be fixed, all kept in the OR. A patient directly, he doesn't move anywhere else. He directly gets into OR. Operation theater gets closed once everybody enters. And once you intubate, nobody should be there. Only anesthetist should be there. That should be a rapid sequencing intubation. And once that intubation is done, then move the patient, ask everybody to come in after 15 to 20 minutes. And similar thing happens with respect to extubation. So what I'm trying to say is that at no point of time, this is American College of Surgery, no point of time, international or national. At no point of time, American guidelines or UK guidelines or national guidelines have said that every patient who comes into the hospital needs to be tested. So there needs to be a symptom-based screening, and that is what is recommended still up till now. So there has been some press coverage which is completely wrong. What we need to adhere is a complete safe mechanism to transfer these patients. Even for anesthesia, what is recommended is 2 filters, dosing has to be appropriate, coughing, airway ventilation, manipulation should be there, and longer shifts if they can take. It cannot be that one group of anesthetists just take care of one patient. So if it could be done that way, that would be perfect. For critical care, this is the position statement from Indian Society of Critical Care Medicine. Mild and moderate. So if it is PF ratio is greater than 150, non-invasive. If PF ratio is less than 150, invasive ventilation. And then lopinavir and ritonavir along with oseltamivir can be given, and other than if there are secondary infections in steroids. For endoscopy, again, you need to wear enhanced PP. It is high risk, and that should be there. For bronchoscopy, if you can avoid bronchoscopy during this time, that would be perfect. Send these patients back if you or have a 7-day of isolation, and then do a batch bronchoscopy, all of it in one particular day, because it's highly risky. Similar thing goes for nebulization. Nebulization also release lots of aerosols, and that risks should be avoided. You can do dialysis. Don't send them patients to a COVID hospital, because room dialysis, hepatitis B, C, HIV positive dialysis was always done, and that needs to be followed. So it can happen in all hospitals. So there is absolutely no change in protocol. There is no change in protocol in obs and gynae. If you are giving an antenatal corticosteroid, that still could be given. Forceful exhalation of second stage of labor is not aerosol generating. So if they have come as positive, don't send them anywhere else. It could be taken care at your facility, and they need not be again investigated. A mandatory test has been withdrawn from ICMR, which was there earlier. So I'm just ending another 3 to 4 slides. If you have worked in the hospital, and it could be a COVID or non-COVID hospital, when you come back home, wash your linen with 60 to 90 degree of temperature, possibly with a detergent, and that should be good. If you think if it is a soiled thing, add 0.05% of chlorine with a contact time of 30. And this is good enough, and you can be completely safe. For biomedical waste management, everything goes into yellow. Everything goes into yellow with a separate COVID bin and tagged. the plastic goggles and the face shield gets into red, and that's the revised Central Board pollution guidelines. Dietary, no change. The food safety and security have mentioned that all utensils are to be washed with hot water and soap, and that's what is the practice. So I'd like to end here that what we need to do is believe authentic sources. And these sources are WHO, Ministry of Health, NCDC, and ICMR, apart from various other bodies like HPI and PHFI who have been working hand in hand and doing fantastic work. So this is there from my side. Take home message: good infection control practices, health education and safety is important. Differentiate between non-aerosol and aerosol. Don't mandate tests because it's not recommended. And wear high and level 2, level 3 PP only for aerosol generating. Otherwise, cost is a concern. And I wish all of you a very, very safe healthcare practices. Thank you very much. Thank you, Dr. Gyani, for giving me this opportunity.
Thank you, Dr. Sanjeev Singh. I think in a small time of 25 minutes, you have covered every bit of what the people have come to listen to you. And I'm sure this is going to give a hell of a lot of general confidence to all the healthcare workers. Now, I think you have to hold on for some time because we may be raising a few questions for you. But because I have galaxy of the experts with me, I would like to engage them at this point of time. To begin with, Dr. Sunila Garg is with us. And one of the questions which some of the chat boxes are raising is, there is a controversy on use of hydroxychloroquine as medicine as well as on prophylaxis. Provide your views on this. This controversy has been going in the recent days. So can you tell us the participants wants to know? Yeah, please unmute.
Yeah. This is one of the oldest drugs which we have been using, and now the trials are on. One of the studies which Lancet has recently brought out, they showed that it is not effective. But as far as ICMR recommendations are there, and my own observations. You see, I'm also working on set of clients which are there on hydroxychloroquine, and then we are watching them over a period of time, and I'm taking both the groups, hydroxychloroquine, the patients who are the healthcare providers which are on hydroxychloroquine, and the persons who are healthcare providers who are not on hydroxychloroquine. So right now we are going to follow them for 12 weeks, and we are going to see the end point is going to be occurrence of COVID-19 infection, and the second point is occurrence of any side effects. So as of now, there have been about 5 weeks of enrollment, and there are 5 healthcare providers who have turned positive out of 215. So I cannot say right now that it is going to be what difference it is going to make, but people complain of basically the side effects due to hydroxychloroquine. That is inevitable, but at the same time, you see, our main focus is to look at whether endpoint is going to, whether this is going to avert occurrence of COVID-19. That I'm yet to see that. But our because there are no proved definite confirmed studies to say that. It's on, because we have never tried in context of COVID-19, and there are very limited studies in that regard. So, but then it definitely, people say that it averts initial symptoms due to, and makes the disease less milder, but I'm yet to see that exactly.
You have to unmute yourself.
That they are asking it, should we have restriction on testing for asymptomatic cases as being proposed by some of the states? Because they are saying that why restrict the testing? Because you may find the carrier among the asymptomatic cases, and which may give us the good trend, what is happening in that area. What do you think as an expert?
Dr. Gyani, this is to me exactly, this question.
For you.
Yeah, so basically, you see, I'll say that there is ideally, in surveillance part, when we are going from house to house survey, or whether we are in the hospital care settings, we are looking at two kinds of patients, that is ILI cases or SARI cases. That means severe acute respiratory infection cases. But at the same time, your point is very valid that quite a number of persons, almost 85% of the people are either mildly symptomatic, and now what we are looking at, the trend is that they are asymptomatic. So in all practical situations, and your philosophy and science will say that they should be tested, but we have to prioritize our resources. We are doing almost over 1 lakh tests per day, and right now in our guidelines, as per guidelines, we are testing people who are either travelers and symptomatics, who are either suffering from ILIs and all that. But even from house to house survey, our workers are identifying these and they are subjected to testing. But your point is very valid that if our resources permit, we should be going for testing of asymptomatic individuals also, because now when we are getting community transmission, it is better to focus on testing of asymptomatics as well, because that will give us the real burden of infection. That is important, because we see,
Yeah. Thank you. One question for Dr. Sanjeev before I go to Dr. Vijay Agarwal. Can we use central pipeline for the medical gas supply?
There is absolutely, it could be used. There is, up till now, there has been no study that it is getting transmitted from central oxygen vacuum or medical gas. So the brief answer is yes, it can.
Okay. Now I bring in Dr. Vijay Agarwal, because I think Dr. Sanjeev Singh covered that teleconsultation now is a possibility, and it has been so around of India. CAHO has been working extensively in the field of consultation, telemedicine, and all related aspects. Now, can you educate us that in this current scenario, how the use of medical technology is all the more important, and how this is more relevant for these modern
Thank you, Dr. Gyani. I think, like you said, that Dr.
Ravi Khanna to please mute yourself. Dr. Ravi Khanna, please mute.
I'm not able to start my video, but anyway, I request other people, and they have to be put on mute. There's a lot of. We can say at least one very huge impact of COVID has been on telemedicine.
The voice is not clear.
Can you tell your administrator to put other people on mute, please?
Hello. Hello.
Yes.
Yes, Vijay, continue.
So the impact of, I would say, COVID on telemedicine has been that telemedicine itself already was a very growing field. But what COVID has done is that has given a real boost, and a lot of fence sitters, which were there, both, I would say, in the terms of healthcare providers and community, they are all now very eager to start using telemedicine. I think what I normally say is what there is one Bhushan Palla. Can we mute her?
Daddy.
Okay, thank you.
Yeah.
So,
Couldn't get that last answer. Couldn't get that.
yeah, so I said what demonetization, I think, did to the digital monetary transaction. COVID is done to promote, I would say, digital health. Now, digital health has come in a big way and is going to be a new normal. If we are going to say that it may just go away with time, it is not going to happen. So one of the biggest things, like Dr. Sanjeev Singh explained, that on 25th of March 2020, for the first time, the telemedicine guidelines were kind of published by the Board of Governors,
Absolutely.
which has been a huge thing. Why is it huge? I think you must understand that so far there was no clarity amongst the medical professionals whether it is legal to give any telemedicine consultation or teleconsultation or video consultation. Was it legal or not legal? There were more people saying that it was not legal because, let's say, even a state like Karnataka Medical Council had given certain kind of, I would say, notices to the doctors warning them that they should not resort to telephonic consultation. And if they will do so, there will be dire consequences. So this particular publishing of these guidelines, in one stroke, that issue of legality has totally gone away. So now it is perfectly legal for any MBBS doctor. Although the telemedicine guidelines uses the word registered medical practitioner, but please do not confuse, it is not for a I would say, it's not for a quack or anybody. It's only for the registered medical practitioners with the state or the central medical council. So any MBBS doctor or specialist doctor can very legitimately now do teleconsultations in any medium that he chooses, whether it is video, text, WhatsApp, social media, any medium that he chooses, he can do it. The thing is that he has to apply his own professional judgment to see whether what he is doing, is it what medium he is using, is it appropriate or not. And in the present situation, you see, when the people are all kind of locked up inside their homes, they are not coming out, you are not able to kind of meet your patients. So I think it is extremely, I would say, important that you should seize up this opportunity and start resorting to the telephonic and telemedicine consultations. In fact, I will say that a lot of hospitals had, patients, they are not in touch. They should proactively, in fact, they could have been in touch with those patients to say and to ask that, are you okay? We are fine. If they need any help, all those kinds of, I would say, counseling and help can at least start almost right away. You see, once these guidelines came, the problem that has now started to happen is there is a mushrooming of the platforms who are providing telemedicine consultations. So there are dime a dozen every day. You may be contacted by one person or the other who says that, why don't you use this platform and why don't you use that platform? And I think that is where, just like it is like altogether a new medium, so the doctors may not fall prey to it. So it is from that point of view that I have been instrumental on behalf of the, I would say, from CAHO, the Consortium of Accredited Healthcare Organization, along with many other organizations. We have formed an alliance to create a registry of the telemedicine solution providers, as well as creating that registry and evaluation. So that data is now available at telemedregistry.in. At telemedregistry.in, anybody goes, can have more than 150 telemedicine solution providers. List is there, and they have been all kind of their various parameters, features which are there, are there. Now, again, another thing that I would like to kind of bring at this point is that when you start going into digital health, and telemedicine is going to be one very, very great arm of that digital health. So another thing that has now started to happen is the problem of cybersecurity. So which most of us are actually not aware. We have done a survey where we find that 80% of the doctors and the healthcare workers are really not aware about the concepts of cybersecurity. And this cybersecurity, you see, the data that you are you're treating your patients, all the data which is there, so there is something known as the dark web, where if you go, you will see that there's a huge price that the people are ready to offer for that data. So the issues of cybersecurity are extremely important, and that also we are trying to address. We are trying to develop a self-assessment tool for the hospitals and the healthcare workers to assess that are you ready for the cybersecurity issues, and you will need, I would say, further guidance and training on this issue. Another thing that again we should be aware of, that just like there was at one time we were bothered about the Consumer Protection Act. Now same thing, I can tell you one thing, that in relation to now the digital health has come. So there is something known as a Personal Data Protection Act, and also another act that is coming up, Judisha. So this Personal Data Protection Act has also been already passed by the cabinet long time back. This will have huge consequences, because for all the data, if it gets leaked, and the leakage could be at many forums, including the platform provider, it could be ABC, but somehow or the other, at the moment, the doctor is being held responsible for that. I am now here, Dr. Vinay Aggarwal is there, Dr. Aggarwal and Dr. Gyani. I'll say that we have to join our forces to really study the implications of this Personal Data Protection Act and save the profession from any unintended consequences. As far as the telemedicine itself is concerned, I think it has fantastic future with the with the advent of the artificial intelligence, and also something else known as the IoT. I hope that people maybe should be aware of IoT, are the Internet of Things.
Okay. Yeah. Thank you, Dr. Vijay. I think this is excellent information. We will definitely connect the CAHO activity on teleconsultation, telemedicine with the group. And now I come to Dr. Arun Aggarwal. Dr. Sanjeev Singh did cover in brief, how do we go for take care in the aerosol generated procedures. But there is two questions specific for you, that for ENT surgeons and for the dental surgeons, can you elaborate, because there is a hell of a lot of fear, particularly in these two specialties, including even the ophthalmic. But if you can focus on ENT and dental, provide us the guideline for the dental clinics and for the ENT surgeon. How should they generate that confidence back and be safe from this pandemic infection?
Thank you, Dr. Gyani. First of all, I'd like to apologize the organizer and my moderator, Dr. Gyani, for my joining late, because I was connected to WHO Geneva for something important. But I think very valid question you have asked, that whether it is ENT or the dental or anybody who is working in close proximity with oral cavity or nasal cavity is at a vulnerable risk. It is not only the risk of droplet infection, but the aerosolization. Both the things are very important for us to protect ourselves. The usual precautions, what is being advised from time to time, but in the case of ENT surgeon and dental surgeon, I think most important area we have to identify is now what sort of surgery we can undertake. We have to categorize the surgery based upon the emergency basis, number one, and number two, based upon the risk. Any surgical on upper airway is at the high risk. Anything which is endoscopic is at the high risk, whether it is nasal endoscopic, whether it is nasopharyngoscopic surgery, or anything to do with trachea or esophagus or wherever it can go. Right? Even in mastectomy, even in mastectomy also, when we do mastectomy, hello, am I audible? Dr.
I think
Girdhar,
there is
am
some
I audible?
crosstalk
Yeah,
going
you are
on.
audible, but there is
You
a
are
lot of
audible. Again, there are some people who have, I think there is some, Sir Salia, can you muted?
Yes. So even in mastectomy, whenever we are drilling the bone, there is so much of bone dust. That bone dust itself is very harmful.
I think
Same is true
some
in
people
dental.
need to be muted.
Yes, can we request them to keep themselves on mute?
Dr. Sushil Gupta will have to mute himself.
Yes. So even in dental surgery, whenever we are doing the process of dental surgery, drilling of root canal and etc. are at a very high risk. There are certain guidelines which has been prescribed by from time to time. Recently, I would like to share with all my colleagues from ENT. I can say a good number of colleagues from ENT also, that our Academy of Otolaryngology, especially for ENT. But main message is that we have to categorize our emergency criteria in terms of the patient's need, in terms of the risk factor. Add the risk factor, can we postpone it? Number two, that can we try to do this surgery after a month or two so that there is no risk to the patient. If we adopt this practice, perhaps ENT practice and dental practice are the one which, as per the past 3-4 years, 3-4 months experience also, there are reports of our colleagues getting infected. So our colleagues have to be very extra careful whenever they want to start.
Okay.
Thank you very much.
Thank you, Dr. Arun Aggarwal. I have kept a most difficult question for Dr. Vinay Agarwal. The private healthcare industry is under the severe disruption. More so, I'm talking about the financial. All the other industries, government is trying to come out with a scheme of supporting, giving subsidies. But the healthcare industry, which is supposed to be in the all preparedness, even when we had very limited patient footfall these days, but we are supposed to be in the full preparedness to take care of the way, not only for the COVID. So I think I want to ask Dr. Vinay Agarwal, with the kind of profile he has, what to the government? How do we really take care that this industry survive and rather flourishes and come out stronger post-COVID era?
Thank you, Dr. Gyani. I'm really surprised, if you really take this COVID journey and when you track it, initially this COVID issue was totally undertaken by the public hospitals and public healthcare. And when we go initial lockdowns, total clinics, diagnostic units, and the small nursing homes and medium-sized nursing homes were all closed. They went in a financial crisis for closing their establishment for 2.5 months, maintaining the salaries of their staff, nurses, and everywhere. And probably nobody thought that this sector, which is catering to almost about 55 to 60% of the private healthcare, and is been neglected as far as the journey is concerned. Now, I'm very happy that from Prime Minister onwards, everybody showered praises and everything. I think that was the only incentive which doctors were supposed to get, or the brickbats by the society. Or now, I always say that from warriors to, Bhagwan se shaitan. Yesterday, Hindu covered it, that the hospitals are the hottest spots of hotbeds of infection. Now, this is what exactly has been happening. Now, central government declared 20 lakh crore package for the rehabilitation of everybody concerned. They talked about farmers, they talked about laborers, they talked about industry, they talked about everything. They talked about shareholders, they talked about big industries. Everybody was taken care of except health industry. nothing was announced as far as health industry is concerned. If you see in the market, if you see in the public, just see the doctors are not getting salaries also, who are serving in COVID hospitals and others. The daily administration has asked central government that they don't have money to be paid to doctors. And the municipal corporation of Delhi is not paying doctors for the last 2 or 3 months. And besides it, this small nursing homes, clinics have been closed. Nobody ever thought about it. We at Indian Medical Association have raised an issue with the health secretary, with the health minister, as well as with the MSME secretary. When MSME, this thing was announced, that lot of privileges were given to the micro, small and medium-sized industry, which actually it was enterprises which covered manufacturing as well as service industry. We thought that why not in service industry, healthcare also comes. Government will automatically announce it, that service sector has. And now if you see the medium enterprises, medium-sized enterprises, they have gone up to the 250 crore turnover, which almost covers a substantial number of institutions with 50 crore investment and 250 crore investment. So we are looking from the government, and practically have been assured also, and I've been writing on this issue, that why not small clinics, nursing homes and medium-sized hospitals be covered under MSME. Now, if suppose government comes out and just extend the definition of service in MSME, the healthcare will also be included, and when the healthcare will be included, lot of soaps will be given to the health industry. I will not call it soaps, I'll call it, at least they will be able to revive themselves, whether they are taking loans at a lower rate, whether they are moratorium period, whether they are, some concessions as far as payments are concerned, and lower electricity rates and so many things. So those are the benefits which this industry will come. I'm sure better sense will prevail on the government, and they will define this service sector in MSME, and healthcare will be included in that. I think that is the only way to revive this small nursing homes and hospitals and clinics. Otherwise, the day it will be there when many of them, you all know, that hospitals are getting closed. The doctors are not having courage to open their clinics, and even now disciplinary actions have started on small nursing homes. The Delhi government's last order that 20% beds should be allocated for COVID treatment without even going. They are residential nursing homes. They have one entry listing. They can't differentiate between COVID and non-COVID. There is nobody to listen to it. And so these kind of repressive actions regressively done. And I think these are the things which should stop immediately. This table tennis ball from one end to the another end, and doctors are getting affected. These industry, rather I'll call it an industry. I'll have no hesitation calling it an industry, is getting affected. I'm sure the government and our honorable Prime Minister, besides giving flowers and praises, will also look into it, the ailing in this industry, which is in the form of small nursing homes and clinics, and do something for this. And I think the best way in today's circumstances is just a small change in definition, and healthcare be included in as a service sector in MSME. That is the only answer which I have.
Thank you, Dr. Vinay. Actually, I have been in touch with the MSME ministry on this point, and I have been told that this case has been put up to the level of secretary now, and hopefully next 2-3 days something will come out. So I think I was in touch with you. You are, of course, we are working together on this issue. Dr. Sanjeev, there is a small...
We met Gattari also, and who has also assured, and I'm sure something will come out.
Okay, yeah. There is one question, that any updated guideline for non-COVID laboratories? Have they issued any updated guideline for the non-COVID laboratories? Is it so?
So non-COVID laboratories remains as it is. There is no updated guideline. They need to follow the same precaution. And Dr. Sunila wanted to add something.
Yeah, we have to follow the standard work precautions, but at the same time, we need to be cautious that our non-COVID laboratories also, because since now we are getting asymptomatic cases are also there. We are handling the specimens, though it may not be, while handling, we are getting different kinds of samples. So we have to be very, very cautious and follow standard work precautions. We don't have to have any breach in terms of taking the preventive measures. So there are no new guidelines, but at the same time, we need to be really, upfront in following the standard work precautions.
Okay. So I think with that, we come to the end of this webinar. I think
only one line I will add, Doctor. I'll only add one line.
Yeah. You're muted.
Yeah, we have to make use of M health also, as far as because during this period, lot of cases of NCDs and all have also got neglected, like diabetes, hypertension, and all that. So M health can play a very important role in terms of continuing with the medication adherence and all that, and also with regard to any complications due to controlled diabetes and all that. So I have been making use of this without even when the official telemedicine guidelines came. So they are really effective, because if regular SMSs and all, they go from the provider side, they make a big difference, especially now in the COVID era, when NCD people are not able to access our services, or TB patients also. So that is very important.
Thank you. Dr. Rai.
Gyani, I can raise Dr. Gyani.
Yes, please, Dr. Vijay.
I think one of the another problem that we are taking it up, but also is the reimbursement by the insurance companies regarding teleconsultations.
Yeah.
You see, unless or until there is going to be this reimbursement, this is not going to be a great movement forward, because every time the doctors are being taken for granted. We have been giving telephonic consultation, I think, since time immemorial. Can you ever talk to a lawyer and get that kind of a free consultation? So now, once it is legal, I think now Star Health has shown some interest, and we are working with AHPI to see that something else happens about it. But I think that's where I will say that, Dr. Vinay, I think IMA should also now take up this cause also, that the telemedicine consultation should be reimbursed by the insurance companies at the same rates as the physical consultation.
Yeah.
Perfect.
Yeah, Dr. Vinay, you want to say?
No, I mean, I agree with Vijay, and I'm sure this is an important issue should be taken up.
So I think at the end of it, I will only say that purpose of this webinar was to have that confidence among the healthcare workers, doctors, nurses, that there is nothing to worry and we can deal with this COVID confidently. That I think we have been able to sort out. But the bigger problem is now that healthcare industry, which has undergone this disruption, I think there is a hell of a lot of serious introspection required on the part of government and on the part of private sector. We have realized the big gaps in our healthcare delivery system, which have become evident thanks to the COVID. And I think this is a time that we, the kind of capability and expertise we have among our country, we can really be the leaders in the healthcare industry, the way we have the leaders in the IT industry. There is no exaggeration. We are capable of doing it. And I think the kind of experts which we have on this panel today work together and able to achieve and make the healthcare as the topmost employer of the country, healer of the country, and taking care of the well-being of the whole population. So I think with that, I convey thanks to my key speaker, Sanjeev Singh, 4 experts to whom, as I call, they are the institution by themselves. And of course, at the last but not the least, Amresh Kumar Tiwari for bringing up this very important subject on the behalf of Double Helical magazine. So we wish him all the best and thank you once again. We'll hopefully meet very soon on the